Ryan Stanton here with ACEP Frontline. And before we get started today, just want to get a little shout out for our upcoming conference, ACEP 26 in Chicago, Illinois. I'll be the incoming president of ACEP, so please join me for the 2026 ACEP Scientific Assembly. It's October 5th through the 8th in Chicago. It's your specialty, your people, one place. Go ahead and get online now and register at acep.org/ACEP26 and get free access to ACEP anytime. And I hope to see you there. And wanted to knock that out because we've got the big conference coming up, but most importantly, we've got right now a guest that I actually learned about through the AMA. I was doing, as president-elect of ACEP, you end up representing the college with the AMA, and I was, the opportunity to go out and attend the state advocacy summit. And Representative Ben Bowman was actually there and spoke and enthralled with the conversation because it really is something that's a huge topical conversation within emergency medicine, and that being the corporate practice of medicine, inside investments within medicine, especially emergency medicine. And of course, I'm sure he wasn't predicting it at the time, the PeaceHealth and issues that have just happened recently to test out that legislation. Representative Bowman, he is a long time, and when I mean long time, I believe 7th generation Oregonian, and so his family's from the way back, and really got his kickoff into before politics and education, and now in politics is the House Majority Leader and really cranking things out there. Now, for those watching on the video side, you can see his bookshelves of a number of volumes there, and definitely that kind of education feel for it. For those on the audio, just trust me. Just get the whole Ron Burgundy leather-bound volumes feel, and you got it. All right, so Representative Bowman, first and foremost, thanks for joining us on the podcast, and give us a little background on yourself, the stuff that I didn't mention.
Yeah, thanks, Ryan. I'm really excited to be on the podcast with you and appreciate the invitation. I am a 7th-generation Oregonian. My family originally came to Oregon on the Oregon Trail, and I love this place. I love Oregon. It's the only place I've ever lived other than when I went to grad school, and this is home. So really want my state to be a great state, which was part of the reason why we took on the corporate practice of medicine bill. But before I was in the legislature, I worked in the legislature for a couple different legislators. I was served on my school board and eventually got elected to the legislature. And I stumbled into healthcare issues because my mentor is a guy that some of your listeners, I'm sure, will remember, a guy named John Kitzhaber, who was governor of Oregon and also an emergency room physician earlier in his career. So he told me, you've already got a good handle on education issues. I'd worked at the Department of Education and on the school board. He's like, the other biggest part of the state's budget is healthcare. We spend a ton of money on healthcare. And he's like, if you can get a grasp of education and healthcare, you'll be well situated to understand what state government is all about. And so over the last 4 years, with Governor Kitzhaber's help, I've really dived into the issue. And that's how this bill, this idea came to the surface as a pretty prominent issue in my state and across the country.
And we're going to dive into that and kind of the background, because right now what I'm seeing is, there's been outside investment within emergency medicine for many, many, many years. Some of it's just the business of medicine in general. Some of it's seen as a profit opportunity, consolidation across the healthcare spectrum, whether vertically or horizontally. Even now, my dermatologist that I go to, they just got bought out by private equity. A lot of dentists now are getting bought out by private equity. And so, there's that's a huge topic across the span of healthcare. And kind of get into how that became. You mentioned that your mentor within the legislature is an emergency physician, so very well aware of kind of those pressures. Talk about how the CPOM and corporate practice of medicine really built up for you and became something that to get the idea to kind of lead forward on this legislation.
Yeah, so here's how I came to learn about this and what sort of prompted me to want to be the champion for this bill. So to your point, Ryan, like the speed at which we are consolidating in the healthcare ecosystem is unbelievable. It's happening very, very rapidly where clinics are being bought up, private investment is coming in, and consolidation is happening rapidly. The research on that shows that when rapid consolidation happens, prices tend to go up, quality tends to go down, and physicians tend to burn out. Those are three really bad outcomes if you're a state policymaker, because they raise your costs, they lower your quality, and they make care more scarce. So I got all this data about how consolidation was happening quickly, how corporations were picking off these smaller clinics in my state, but across the country. There was 100,000% increase in private investment into primary care in like a 10-year period starting in like 2011. I mean, the scale of this is almost unbelievable. And so that was one piece of information that I was told and learned. The second piece was about what's called the corporate practice of medicine doctrine. So most states across the country, red states and blue states, already have what they call a corporate practice of medicine doctrine. It basically says physicians have to be the ones in charge of patient care. You can't have a corporate owner dictating care or dictating clinical decisions. It was like a byproduct of like a coal mining era when, the coal mine bosses were putting in these doctors and telling them to get these people back in the mines. So most states already had this prohibition. And in Oregon, what the prohibition says is a corporation cannot own a majority stake in a medical clinic. So how on earth would it be possible for Optum and private equity and other large corporations to own clinics in Oregon if we have this law that says you can't do that? And the answer to that question is, over the last 50, 70 years since CPOM was implemented in Oregon as a legal doctrine, they have figured out a bunch of legal loopholes to get around the regulation. The most prominent of which is the friendly physician model, or the captive physician model, which was what was proposed by PeaceHealth in Eugene, which is you find a straw doctor, someone who doesn't have to live in Oregon, doesn't have to practice at the clinic, doesn't have to have ever visited the clinic, but on paper, they'll be the owner of the clinic. They will route all the decisions through the corporate MSO. And so on paper, there's a doctor owner, but in practice, a corporation is running the clinic. What our bill did, among other things, we can get into the details, is we basically said you can't do that. You can't have a straw doctor running a clinic. You have to have a doctor who's invested in their patients running the clinic.
And that is huge. And we'll dive into all the stuff that happened that made your spring much more exciting than it probably was expected to be. You've been in the legislature since 2022. I think that's the year, if I remember correctly, you came in, hit the ground running clearly. I mean, we're only 4 years in, and I heard about this at the beginning of 2026. And so, something that happened before. Kind of get into the details of the law and how you close that, because that is a big argument that takes place. Is the CPOM is something that exists almost universally across the country, and yet you're absolutely correct. There's these little manipulations and things that allow folks to continue to kind of move the needle, and I find it hard to believe. I mean, being somebody who started in a medium-sized group that was owned locally, ended up being bought out by private equity and eventually by a larger private equity-backed group. A lot of it had to do with, unobtainable goals. I mean, it was always these things where, you can get a bonus based on RVUs and those types of things, and there was always a moving goalpost. And the fact that it wasn't as much telling you how to practice, other than the fact that it was, the staffing side of it, changing up your patients per hour and things like that. And the argument was always, well, your payment doesn't change because we actually have a more efficient way to collect on these charts. And, so it's me personally, I'm one of those things, I don't care the size of your group. I just care how you treat your doctors and their ability to treat the patients. But at the same time, it is the whole idea of which God do you serve, if is your primary business model to make a profit, or it is to provide the best possible care. And, now being part of a group that has 2 hospitals, of course, we're invested in our communities because we live in these communities. Mm-hmm. So talk about what you built into your legislation that close those loops and those details that then will roll into some of the PeaceHealth side of things.
Yeah, great question. So there's I'll break it into 3 big categories. I will start by saying this is genuinely a complex piece of legislation. It is very long. There's lots of different sections and provisions. And that is because the loopholes that have been crafted are quite complex legally. And so closing them was not easy. But 3 big categories. One is about physician control. So what our bill says is that control of a medical clinic has to be held by physicians. And we define control quite broadly. Things you mentioned, how much time a doc spends with a patient, appointment times, staffing decisions, billing decisions. Control has to rest with the doctor. Now, that doesn't mean the doctor has to execute the function. The doctor can hire, we're not anti-MSO in this legislation. We are saying that the control of the function rests with the doctor. You can hire someone else to do it for you, but you have veto power. You have the ability to direct that function. So that's number one. Number two is limiting contractual restrictions that are used to control docs. So the most prominent of which is non-compete agreements. We dramatically scaled back the use of non-compete agreements. We had doctors in my state at a time of a physician shortage sitting at home not seeing patients because of a non-compete agreement. Didn't make any sense. Closed that loophole. We also regulate, do you know about STRAs, stock transfer restriction agreements? Is that part of your employment package?
Not for me with my current group, but we've had them in the past, yes.
So basically, these are ways, again, to leverage control over physicians. You basically give them an equity stake in the company, but then the corporate owner controls when you can cash it out, who you can sell it to, the conditions under which you can sell it. It's just another tool to compensate but exercise control. And so that's a second category about contractual provisions. Third big one, and this is how you get to the root of the friendly physician model, the captive physician model. We prohibit what's called dual employment. So we basically say if you're a doc, you can either work for predominantly the clinic or predominantly the MSO. You can't be the owner of the clinic on paper and be compensated by the MSO. Because that's how you prop up a straw doctor. Like in the PeaceHealth case, the doctor made clear to the judge, I'm not moving to Eugene, I am staying in Chicago. And so that man would have no knowledge of what's happening in the clinic, but was by what was shared in court, was allegedly working for or had previously worked for the venture-backed corporation who was seeking to take over the emergency room contract at PeaceHealth. So basically, you eliminate the possibility of a captive physician, and you say, to your point, you have to choose: are you going to be on the clinic side, or are you going to be on the management service side organization? We didn't get into this much. Maybe your listeners are already familiar with this, but the management service organization, the MSO, that is the subsidiary that the corporation or the private equity firm creates to run the clinic, to exert control and authority over the clinic. So that was the relationship that we sought to regulate, was the relationship between the MSO and the clinic. Instead of having a relationship where the MSO runs the clinic, the way it's supposed to work is the clinic is the owner and they contract with the MSO to provide services on their terms as a physician-owned group. So one way to think about what we're trying to do with this provision is reestablish the proper relationship between a physician-run practice and a management service organization.
And that's like what we do here, where Central Emergency Physicians owns the group, and then we hire out the management operations, and then but still everything runs through us. And I get, interestingly, when you talked about the stocks, it just reminds me, it's almost a flashback. About 6 years ago or so, my group, some of the leadership was about ready to retire, and they looked to sell our group to get the equity out of it. Mm-hmm. And it was APP, and I'm sure you know the history of APP. And I still remember, what we were going to do, what we were going to make, our, the decrease in our hourly wages and the compensation to prop up was going to be those stocks. And I still remember talking to physicians since that closed down, because I was on the ACEP board once when that closed down, and dealing with the physicians that were, lost their coverage, didn't have malpractice protections, didn't have, basically everything. But they also told me, I've got hundreds of thousands of dollars of stocks that are worth nothing now. There's $0. So it's basically, something that doesn't mean anything. And there's one thing I can tell physicians out there. I mean, if you trust and believe in a company of whatever it is, whether it's healthcare or not, enough to have stock in it, then go for it. But understand that if it is a situation like this, in the very end, it could very well mean nothing and be a value of zero.
Totally. So, well, and on that note, I got to give a shout out, hopefully the first of many, to the Eugene Emergency Physicians. So part of the business model for when these guys come in, venture-backed, private equity-backed corporations, and they're trying to take a contract or buy a clinic from an existing provider group, their business model depends on those existing providers staying with the new owner. And so they made a bunch of assumptions that all these Eugene emergency physicians, they were just going to be able to gobble them up and pay them a little bit more. Same thing happened with an anesthesiology takeover up in Portland. And what happened was the physician said no. They said, I'm not going to work under these terms. I don't want to be part of a corporate-backed group. And that was part of, I think, the leverage that drove ultimately the court case, ultimately the settlement, like these docs standing up and saying, we're not just going to be bought off because someone's going to pay us a little bit more money. Like that's a big deal. And I think it showed some courage from the docs down in Eugene.
Yeah, and I can't, and as in the leadership role with ACEP, there's, with these group models and the sizes that they are, I mean, there's wonderful, incredible, some of the best physicians in the country are working for, what would you consider a private equity or large-based group or corporate group or whatever it may be. And so this is in no way knocks the physicians, is because you're doing what you need to do, which is trying to find a place where you want to work and provide for you and your family and things like that. And, again, from my standpoint, it's really how do you treat the physicians and ensure the best possible care. And, that was interesting because you mentioned the Eugene emergency physicians, and that's actually what we have contractually with our hospital where I work, is the fact that if they choose to replace us with anybody, every one of us leaves. So they have to start from scratch, and that's in the contract. And so if they can choose to do whatever they want, but you're going to be starting over. And we are a very similar type group, and we've been with our hospital for almost 4 decades, and now expanding just a little bit with our model. But we've seen a significant growth in physician-owned and managed and run groups within our region, simply because of the hospital investment and wanting to have local people doing local control, providing local care. And that's the big thing for us, is providing physicians those tools to say, when a hospital's looking, we have a competitive field. We have something that's going to allow the best for the patients that are there. And I think that's where this Eugene, Oregon situation came in, is the fact that, this is almost like the bomb that was dropped. And this isn't the only place where we're dealing with this type of thing. We saw a similar type thing happen down in Jacksonville, Florida. We've seen similar in Virginia. We see them in a lot of different places where we see these long-time, 30-plus-year groups that are being replaced, usually because of the hospital. And in my personal situation with this thing, looking at it from the ACEP, from our standpoint, was the fact that, both groups were doing what groups do. They were doing the business of medicine, but it was the C-suite that was driving this whole process. So kind of give your timeline of as this situation in Eugene kind of broke down and you became involved with it and how it related to your legislation.
Yeah, it was, to your point about the spring that I didn't expect, it was a pretty wild turn of events. The bill had been in effect for less than a year, just a few months actually. And there was this announcement out of Eugene, which is a major city in Oregon, and has been through a whole host of challenges down in Eugene. There was the largest medical clinic in Eugene previously was taken over by Optum. A bunch of physicians fled the practice. Over 10,000 patients down in the Eugene area got a notification that they had lost their primary care provider and that there was no replacement for them. So that was one big thing. And then they closed the emergency department in Eugene. So there was only one left in the neighboring Springfield, which is the location we're talking about. So the context for Eugene is it had been through the ringer already in terms of the healthcare ecosystem. And then there was this announcement from PeaceHealth that they were no longer going to continue their partnership with Eugene Emergency Physicians, and they were going to move to this venture-backed group called Apollo MD. And I represent the Portland suburbs. I'm way up north. The Eugene legislators down there were on it from the very beginning, including chief sponsors of the bill with me, Representative Nancy Nathanson, Representative Lisa Fragola, and the local community, the mayors, the county commissioners. Like, people were very concerned about this from the very beginning and started pushing back. Our bill has a series of requirements. Again, our bill doesn't say you can't have private equity, you can't have a corporation, you can't have venture capital. It regulates the behavior and the structure. So what we said as legislators after this announcement was made was, okay, can you please demonstrate to us what your corporate structure is? What is the relationship between the Apollo MD MSO? And they literally just made up a group, a clinical group. I can't even remember what the name was, like the Lane County Emergency Physicians or something. What is the relationship between the MSO and this clinical group? Because our bill makes very clear the MSO can't be running this group, even though the announcement from the hospital was a relationship with the MSO group, not with because there was no medical group. They had to create that in order to comply with the law. So we asked for that information, and the response we got, it's in writing, it's in public, was, well, we don't have that yet. That doesn't exist yet. Okay. So then our next letter said, okay, in Oregon, we have what's called the Healthcare Market Oversight Program. We call it HCMO. It's also a great tool to manage consolidation. Basically, any merger or transaction that happens in Oregon has to be reviewed by HCMO for its impact on access, its impact on cost, its impact on quality. So we sent a second letter that said, okay, we think you should go through the HCMO process and make sure, just as the beginning to determine if you should go through the process. We thought they should voluntarily supply some information, and their response to that was, no, we don't think we need to go through that process, so we're not going to. At that point, the emergency docs decided, we're going to litigate this. We do not believe that this is in compliance with Senate Bill 951. Because the plaintiff and the defendant were from different states, the case ended up in a federal courtroom, even though it's a state law. And we can get into the details, but fascinating developments in the case. And I just have an enormous amount of respect for the Judge Casabai in the case, who very quickly came to understand what Senate Bill 951 was about and held Apollo MD and PeaceHealth to account for not being in compliance with the law. And did so in very direct language, calling them out for, in his words, dishonesty. In his words, he basically said, like, what you're saying to me is it's ridiculous. Like, they weren't able to answer his questions about structure, about control, about who was in charge, and it didn't pass the sniff test. And I think that is what ultimately helped force this settlement that will restore Eugene Emergency Physicians.
And that's interesting because, once we got into the court case, I expected it was going to be, but, even from the word go, day one, I mean, it wasn't looking great for, the PeaceHealth side of things. Just review of some of that testimony, kind of dive into some of that, because I think that's the key thing here is, we had so many people that were so ready to ready, fire, aim with this type of thing, understanding complexity of the relationship with EEP and PeaceHealth. It was not all, roses and walks on the beach before, but at the same time, this is the RFP had gone out. I know a number of groups that looked at that contract. And so, this was something that was kind of brewing in the background, but then as soon as it lands, we got a lot of people that are immediately, taking up pitchforks and torches and ready to march on Oregon. But to me, the most important thing is to kind of get that background. And that's why I love this discussion having with you, somebody who did the legislation and also now living the legislation. Mm-hmm. Talk about kind of how that court case progressed and really come to some of the things that kind of solidified the fact that it did not meet up to the standards that are in your legislation.
Well, I will first say I was incredibly nervous when we found out that this was going to be a case, because the Oregonian, our big newspaper in Oregon, described this as the first major test of our legislation, which I think was the right framing. But the challenge with that is we might have not passed the test. Like, again, very complicated legislation. And when we had reached out to Apollo and said, we want to understand your structure to make sure that you're in compliance, their level of confidence that they were in compliance and their response was a 10 out of 10. Like, by their letter, they were sure they were in compliance with the law. They had done everything right, and they were really excited and happy to be doing it. So there was for sure, this was never an inevitability that the Eugene emergency docs were going to win this case. I think the most important part of the case that sort of was the linchpin of it was the judge was asking Apollo and PeaceHealth to describe the structural relationship between both the hospital and the provider group and Apollo, the MSO. The judge described that arrangement as, quote, a handshake and a wink, which is, in his words, not sufficient to be in compliance with the law. And I think that is ultimately where this all broke down. Like, he was asking, who's going to be in charge of the clinic? How is this going to work? And they repeatedly said, I don't know. I don't know. The guy who was supposed to be running both the the MSO side and the clinical group repeatedly said, I don't know, I don't know, I don't know. So ultimately, their inability to demonstrate compliance with the structural requirements of 951 is what I think did them in. And the judge was just relentless in getting to the truth and continuing to push and continuing to make sure that they were on the record in answering these questions. And again, ultimately, I think that is what did them in.
And so but in the court case, in the end, there never was a full judgment, correct?
Yes, correct. Now, right now, I think there's probably another week or two left. We're recording this on May 14th. They announced a settlement midway through this case, in my view, largely because the judge had made it abundantly clear he did not believe these folks were in compliance. The challenge was he also said he didn't think he was going to be able to rule before this new contract was supposed to take effect. So my view is he was projecting to folks that this is not in compliance and you should figure this out. So they announced a settlement. The case is not like closed and over. The judge is now allowing them to negotiate in good faith a new contract between EEP and PeaceHealth. If they fail to reach an agreement, I think it's like May 20th or something like that, the case will essentially continue and the judge could rule. He is going to, I'm not a lawyer, I'm not an attorney, I'm going to get all the legal words wrong here, but he is, he's not going to issue a decision, but his findings will remain in the record, which I think is an appropriate middle ground there. So yeah, the case proved that the law can work, that the law provides leverage to docs when they believe that their control is being eroded by corporate owners. And I think it's going to give pause to when a group's model is to control medical decision-making, they might think twice about whether they want to come to Oregon because our law doesn't allow that business model. It allows a partnership, it allows outside investment, but you can't dictate control over the top of a doctor.
And I think that's always the physician autonomy is always the piece we're trying to protect as much as possible with regard to that physician-patient relationship. We have to have the support and ability to have that relationship and actually provide the best care possible. I think it's interesting, and just kind of bouncing into some of the other lawsuits that are out there, not against groups, but the lawsuits against like some of the large insurers and things like that with non-payment. Many times they will settle beforehand just so there is no judgment and there is no case law that's developed out of it. And I was wondering if that was kind of the mindset pending this all works out, is that you don't have a final judgment that establishes as case law. But if you say the opinions and standings will still be in there, again, I'm not a lawyer either. I'm a doctor, which means I'm just almost the opposite. And other than a few words of Latin that I can describe a human body, that's about as much as I know. Do you think this being settled as is here without a firm judgment, do you think that, clearly it did not go against the legislation, which is huge, but either way, do you think this strengthens the foothold of the legislation, even if we don't get a firm judgment for either side?
Yeah, great. It's a great question. I've been thinking a lot about this since the settlement was announced. The judge addressed it a little bit at the end of his remarks, where he basically said this law isn't going anywhere. So even though there won't be a settlement, the law is still on the books. And that is obviously true. I think there's the sort of legal question, which is outside both of yours and my scope here. I think a ruling probably strengthens it a little bit. But then there's also the political side. Passing this bill through the legislature was by far the hardest thing I've done in my 4 years in the legislature. It was incredibly hard. There was dozens of lobbyists who were fighting this thing every step of the way. It failed the first time I introduced it. It failed the second time I introduced it. And we finally passed it the third time. So from the political dimension, we now have an entire community, like the second or third largest city in my state, who now are rallied behind this piece of legislation as a critical tool for protecting cherished providers in their community. So I think from a political perspective, the law is more popular now than it's ever been. It got national attention. When it was passed, Elizabeth Warren called it the strongest protections against corporate profiteering in the country. So I think like it is building the case both in my state to strengthen this law, to close any of the remaining loopholes and strengthen enforcement. And we're increasingly hearing from people all across the country, red states and blue states, by the way, who are asking us how we did it, what the policy details are, so they can replicate some version of it in their state. So from the political front, I think the case actually has bolstered why states across the country are going to start moving in this direction.
One of the big things that came across, and you actually answered one of the other questions I was going to ask with regard of how it's going to impact things moving forward. But I want to, chat a little bit about, with this, of course, there was, as I mentioned, there was huge blowback from right off the top. You look at some of the Facebook pages, emergency physician pages, it was on fire and from the very, very beginning. Talk about the actual strategy of advocacy for physicians and organizations with regard to actually moving the needle. I always like to say that great advocacy isn't always loud. Great advocacy is relationships. So talk about the interactions that you had and with other physicians within Oregon and beyond that really kind of made the difference, because really the conversation we had, and you were at the State Advocacy Summit for the AMA and the Oregon chapter of AMA. They were both very supportive of all this, of the legislation, and have continued to support. Talking about some of that advocacy, and you as a legislator, how does it received, and what is the best way for us as physicians to truly move that needle?
Really, really good question. And I think the way you framed it is really important. Loudness doesn't pass bills, but relationships do pass bills. So I will first say this bill 100% does not pass in the Oregon legislature without physician leaders. As I mentioned, we were vastly overpowered on the lobbying front by corporate lobbyists. And I'm not trying to disparage those lobbyists. Like, they were doing their job. They were representing their clients' interests. That's their job. But to counterbalance that, when they're doing meetings after meeting after meeting after meeting with legislators, you need to have some folks on the other side counterbalancing that. And legislators, in my experience, most legislators have very little medical professional experience. So the voice of a doctor is treated as an expert in healthcare, is treated as, even on a policy level or on a budget level, treated as a higher level of expertise. And we were able to mobilize literally hundreds of physicians from across the state. I had a ton of help in doing this. And if you look at the public record on this bill, it was something like 9-1 in favor versus opposed. And of that 9-1 ratio, the overwhelming majority of the people in favor of it were physicians. And those are people who drove down to the state capitol to provide testimony and meet with legislators. Those are people who submitted written testimony online, who did Zoom testimony from exam rooms wearing their coats in between seeing patients because they cared so much about the legislation. And that made a huge difference. And I will say, as I mentioned at the front end, when I first introduced this and got real close to passage, I was a freshman legislator. No one really cared what I thought. But sitting next to me was former Governor John Kitzhaber, emergency room doc, retired, and Dr. Bruce Goldberg, former head of the Oregon Health Authority. And so I was able to sort of borrow their legitimacy and their respect as both doctors and health policy leaders in my state. And that was a key part of the strategy too. So I think using your organizations is an important tool. I will also say, I think the OMA was in a bit of an awkward spot because a large medical association has docs with a lot of different opinions and have docs who are part of a lot of different financial arrangements and compensation arrangements. So I was really grateful that they ultimately were supportive of the bill, but I think it was an awkward journey for them versus some other physician groups, some of the like the family docs, the emergency docs. Like there were some groups who was super easy for them to get on board immediately and mobilize their membership. And I think the larger the group, the more complicated that became. But the emergency docs at the national level, at the state level, have been very, very active in this kind of work and deserve a major shout out.
I know that Oregon ACEP was a major supporter throughout the process, and they not only know they testified several times in support of this, and then of course continued that advocacy when I was talking about some of the more subtle advocacy, discussions and meetings with you, the governor, as well. In fact, I was set up to talk with the governor this week, pending before this came out. And so Dr. Champanis and the Oregon ACEP chapter has been on top of this the entire time. And I think that's an important conversation. And I think that really is what drew me to continuing to reach out to get an interview done with you, is that discussion we had at the AMA about some of these things, the things coming in, needing the voices of physicians. We've recently just done our leadership and advocacy conference up in Washington, D.C., involved with our states, was up advocating up in Ohio yesterday. It's always a battle, but it's important to have those physician voices, not only individual, but as organizations, to be involved to help that. So let's wrap up today with your kind of your mentor within the legislature is emergency physician. Mm-hmm. But in this case, the importance of having those boots on the ground, physician-patient relationship voices involved with pushing your legislation forward.
That's right. I think here's how I would frame it to close. This is an inflection point for the American healthcare system. Not just in my state, but in states across the country. It is changing incredibly rapidly, and we are either going to design a system that is best for patients and providers, or we are going to let this relentless trend towards corporate consolidation and control take a foothold. The number one most effective group of people to prevent that future from happening are providers, are doctors and nurses and PAs. And so I think now is the moment. Most docs did not get into medicine to be involved in politics. I totally understand that. And I know it's an incredibly frustrating process. And as I mentioned, it took us years to pass this bill. But we need doctors right now to get off the sidelines and out of just the exam room and get into the Capitol and get into legislator offices and ask hard questions at town halls and bring model legislation to their legislator. This is just such an important moment for our healthcare system. And once we pass the threshold of corporatization and consolidation, it is really hard to go backwards. So at the very least, people should be protecting the infrastructure that they have and protecting the physician autonomy that they have, and then doing what we're doing in Oregon, which is starting to chip away and strengthen independent providers. I think we have to attack this from both sides. It's both stopping the bad outcomes, but also incentivizing the good outcomes and making it easier for independent providers and provider-led practices to pop up and expand. And that's not going to happen unless physicians are playing a leadership role in what the future of healthcare is going to look like in this country. So I appreciate, Ryan, the opportunity to talk to you about this and the leadership that you've demonstrated in making that vision a reality. We got a lot of work to do, but we can get it done.
Well, the thing I didn't tell you beforehand is I'm actually an Oregon licensed physician as well because of my motorsports background, traveling around to tracks. Yes, advocating for me as well. And I appreciate that. I mean, it is nice that we are getting the focus now, from the states, from the national side, FTC getting involved with some of the integration that we're seeing, especially the vertical integration of the system. And, in my area, we've seen consolidation as a huge issue of taking out the competition and what that does. You look at East Tennessee with the safety ratings of their hospitals that have taken place because of consolidation and the lack of competition and bringing in the physician leadership that is so important in healthcare. It is absolutely integral that at every level of the healthcare system, there needs to be physician leadership. And I will take, as a physician, some of that blame and the fact that we've given away too much. and thinking that others would be able to lead with a similar type of mindset and view that puts the physician and patient relationship at the middle. And unfortunately, I think that gets overlooked quite a bit when you're looking at profit margins, market share, growth, and whatever it may be that does not directly benefit the patient that's sitting in front of us. So with that, I appreciate it. You have a closing thought? I'll let you grab that, and how folks can get in touch with you if they have any questions.
I was going to say the closing thought, and I apologize for the last minute thing, but it prompted me to think of this. It's something that you're going to hate and your listeners are going to hate, but I'm going to say it anyway. You should think about running for office. When a doctor gets into the legislature, which has happened several times in Oregon, including Dr. Lisa Reynolds, who is a big supporter of this bill, a pediatrician, and my mentor, Governor Kitzhaber, who was in the state Senate, like, you can drive change as a legislator, including in states like mine where it's a citizen legislature. You can keep seeing patients. But I would encourage your listeners to think about that. And if you want to get in touch with me and talk about running for office or talk about this policy, email my office, rep.benbowman@oregonlegislature.gov. Always happy to talk about this bill and trying to expand the movement across the country. And thanks again for the invitation, Ryan. This has been fun.
And I appreciate it. And we actually had, we actually had a couple of our emergency physicians, state legislators at LAC. We actually did a podcast with Representative Vinkett and Representative Reeder, and representing both red and blue. And this is something it's a difficult challenge for emergency physicians because politics is very much against the scientific method. We want 1 + 1 = 2. And when I go to Frankfurt here in Kentucky, it is 1 + 1 = house cat or something like that. It is very well designed that one of the largest distillers in the world is located in the same city as our legislature here in Kentucky. And so, yes, my options are to veer off the bridge into the Kentucky River or to go by and visit Buffalo Trace. And one of those is clearly a safer choice for me, at least.
That's awesome.
But I appreciate it, and thank you for the time. I'm glad we were finally able to make it happen. And this fantastic interview, fantastic information, and we appreciate the fight, and we look forward to supporting you moving forward. As for me, you can contact me, rstanton@acep.org, rstanton@acep.org, at EverydayMed on X, as well as encouraging everybody out there to subscribe to the podcast on whatever your favorite player is. Send us a 5-star review. Give us some feedback, but 5-star review is important to help boost us up so we can continue to get these stories out there. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music. Bow, bow, bow. There. Quiet place, all alone. Da, da, da.